Thank you. It's a pleasure to be here and to have a chance to respond to Chamer's talk about continuity and hopefully open up the discussion. Chamer reminded us that continuity is a concept that you can understand in different ways, in terms of relationships, in terms of continuity of information, and continuity of management across providers. And he said there was some evidence of important benefits in terms of mortality, hospital admissions, healthcare costs, patient satisfaction. And they're the things we hear about, but actually the evidence, the effects are quite small, and the evidence base is quite weak. So that sets off in my mind a number of questions. Who's continuity for? Do we need it? It's a bit like Mary said in her first talk, should we just think in terms of averages? Does everybody need continuity? Or is it really relevant to some particular groups of people? And maybe one particular group of people might be people with multimorbidity because they've got complicated problems and complicated needs. So this topic may be particularly relevant to people with multimorbidity. But even if you identify people who need continuity of care, do they need it all the time? Do they need it for every problem that they have? They might need it when they've got some ongoing complicated mental health or social problem, but when they need to get a repeat prescription for their hay fever medication, is it vital they see the same person? And is it equally important in all healthcare contexts? This is something that GPs, family medicine doctors talk about a lot, and it seems particularly important in primary care. But is it equally important when you go to the emergency room, when you've broken some bone or other? And certainly in Britain, it's discussed a lot within primary care, but my perspective, dealing with elderly relatives going into hospital care, is it would be really useful if there was somebody who took overall control and had continuity of care in hospitals. Maybe in your countries you have that, but not very much so in Britain. But I think that continuity, and my kind of hypothesis is that this whole topic is particularly relevant to people with multiple complicated problems, and yet, as Chambers reminded us, these people who have more to gain from continuity actually are less likely to get it. What do we make of all of this? Whenever you have these complicated, these hard to understand problems, and the evidence doesn't quite stack up with what you expect it to show, it's really helpful to think through what's the hypothesized sort of causal chain, what's the logic model for why continuity at one end should lead to benefits at the other. How to do this? Gemma, how do I use the here? Ah. So, I think and it's really kind of spelt out like this, as why continuity should lead to outcomes over here. Well, I think that the kind of assumption is that seeing the same doctor builds trust in the relationship between the doctor and the patient, and that builds relationships, which in turn improves patient satisfaction. And seeing the same doctor builds trust, which might make the patient more likely to do what the doctor talks to them about. And that might promote self-management, which might lead to better health outcomes. Seeing the same doctor means you don't have to explain the story over and over again, and that might help make the consultation more efficient, and that in turn might reduce costs. And seeing the same doctor means this doctor understands you and where you come from and what kind of place you live in and what your family's like, and that might enable them to make better informed decisions, which might lead to more appropriate care and affect whether or not you get admitted to hospital. That all makes sense to me. But two things strike me out of this. Firstly, I've only talked about seeing the same doctor, which is only one sort of continuity that Chamer talked about. And in Britain, certainly, there's a kind of assumption that relational continuity and informational continuity and management continuity are really the same thing. And it doesn't matter if you see different doctors every time, as long as they share the same records and they share the same protocols. But if the causal link is all about trust and relationships and all of that, then it's a completely different issue, sharing the records from seeing the same doctor. On the other hand, continuity of information and continuity of management might mean you don't have to repeat the story, and that might lead to improved efficiency, and it might lead to reduced costs. So understanding what kind of continuity you're talking about and how it's supposed to have its effects might help you disentangle what's happening. And also, this I've talked about seeing the same doctor. Maybe the reason we get mixed effects is because we're measuring the wrong things. So nearly all of our studies on continuity of care have been based on counting whether you see the same doctor, particularly using the continuity of care index. But supposing you're always seeing the same doctor, but you don't like that doctor, you don't trust that doctor, then it's not surprising it doesn't lead to the trust and the adherence and the improvements that we talked about before. So I think that probably a much better measure is, do you see the doctor you wanted to see, not did you see the same doctor? And secondly, if the key thing is trust rather than just seeing the same doctor, there are some doctors who manage to engender trust very quickly and others who will never engender trust. So there are other complicated things going on. And it also tends to assume that this doctor knows something about you. So there's an interaction with information. I'd like to say I know all about my patients, but actually I forget stuff. And having a good record system helps me remember. And there have been studies showing how little doctors actually know about their patients. So are we measuring the wrong things? And maybe that explains the lack of effects. And I think that thinking about the causal pathway helps us think about what we should be measuring. So I think we ought to look at the relationship between seeing the same doctor and whether that leads to trust. Is that necessary and sufficient? Look at the relationship between whether trust is associated with promoting adherence to treatment and whether promoting adherence to treatment is associated with better health outcomes. And if you introduce measures at different points along the pathway, it will help us understand these limited and mixed effects. Chenma's reminded us that the evidence, where it does exist, suggests improvements in mortality, admissions, healthcare costs, patient satisfaction. I saw an earlier draft of Chenma's, and I was trying to reflect and use this to reflect on what he said. Well, my main reflection on that is, isn't that enough? If it's true, do we need any more? Do we need evidence of improvements in health outcomes? I would suggest not. If patients like it, and if it's cheaper, and it reduces mortality, that's good enough for me, if that's true. And my other reflection is it isn't only about the patients. Of course, it's largely about the patients, and the patients are the most important thing. But for me personally, even if there was no evidence it benefited patients, I would still think it was important, because I think it's important to doctors. I think if I get a 10-minute consultation and someone comes in to see me, and I've never seen them before, but I can see that they saw one of my colleagues a week ago to talk about their mental health problem and their obesity and their back pain and their poorly controlled diabetes, and this doctor's trying to make a plan, and I can see they're trying to begin to make a plan to sort this out, and they said, come back and see me in a week. But this patient didn't come back and see them. They came back to see me. I've used up 8 of my 10 minutes trying to get to grips with what all the different bits of the plan are. And there's a bit of me that kind of thinks, is it worth really trying to engage with this? Because they're not going to come and see me, they're going to go back and see someone else next week. Whereas I'm much more likely to care about somebody, and that makes me go the extra mile, that I feel I've got a kind of connection to, a sense of responsibility for, an accountability for. That means that I know this is my problem. I've got to sort it out. I've got to keep seeing this patient until I do get it sorted out. And I think that will lead to better quality of care. But I also think it's important in terms of why anyone would want to work in primary care. I think many doctors work in primary care because they're interested in people, at least as much as they are as diseases. And if you never see the same patient twice, you might as well just have a casualty, send them all to the emergency room and not have primary care at all. But we did do a study on this, and we did a qualitative study talking to doctors about what continuity of care meant to them. And as for patients, it's quite nuanced. It's quite hard work providing continuity of care. It's emotionally demanding, and many doctors didn't actually want that much continuity of care because they find it too difficult to deliver. So just as for patients, there are costs and there are benefits for patients as well as for doctors. Thank you.